Thank you. Well, good morning, everybody. Saturday morning, 8 o'clock, but we're biomeds, imaging people, right? We get up early at 5 o'clock to be to work at 6 to take care of all the emergencies, right? So, but again, welcome. My name is Michael Gossman. I am a modality manager and instructor and radiation safety officer at Althea, US, located just north of Nashville in a town called Goodlettsville, Tennessee. A little bit about my background. I graduated from USAMIOS, U.S. Army, in 1993, and I've been a biomed imaging tech since then, which is 29, 28 years now. I've been in the trenches. I know what biomeds and imaging technicians go through. I've been there. I've been under the stress, and the directors want to know when the unit is going to be up and operational. I've been working on injectors now for about 15 years, and there's really no good explanation out there of how injectors really work. So I put this together. Who knows how an internal combustion engine works? What do we need to make it run? Three basic things. Exactly, fuel, fire, and air. Does that apply to a Lamborghini? Does it apply to a Maserati? Does it apply to a Chevy Chevette? They all have that in common. And of course, the LS, was it 7 engine now? Yeah. They all need fuel, air, and spark to work. It doesn't matter what internal combustion engine you're looking at, you need those three things, the three basic things. Well, that theory and that logic applies to contrast injectors also. You need certain things, certain checks, certain safety measures in place for that injector to work. If you understand the theory behind the injector, what makes it work and why they have what they have, you can understand, you can approach any injector and do some basic troubleshooting. Okay? So that's why I call it contrast injector theory. This is how it works. And again, it doesn't matter which injector you're looking at, whether it be a Bayer MedRad injector, levofloxacin, Covidian, or now Gerbet injector, a cyst injector, or any other injectors out there. You have to have basic stuff to make it work. Okay. My button don't work. Roadblock. My light work. Now my light works.
We can point at you.
We can blind you. So I wanted to present this class to biomeds and imaging technicians so they understand whether you're a biomed working on something in the radiology field or whatever, hey, can you take a look at this? Thank you. With this basic theory, you'll be able to do some basic troubleshooting and let them know what's going on. Fundamentals. We're going to go over what is contrast. What is a contrast injector? Basic operation of an injector. Safety features. They all have them. What is pressure and how does that pertain to injectors? What is pressure limiting? And also basic troubleshooting. What is contrast? Can anybody tell me what contrast is? Can anyone tell me what? There's two different meanings to contrast. One is a noun, which contrast is, this is contrast. And then what is the basic definition of contrast? I stand beside her. What is the difference between us? The major difference. Exactly. So contrast is the difference between black and white when it pertains to video. SMPTE pattern. Who's worked on a monitor or television and they pull up a SMPTE pattern? It's a pattern that you put up there that shows the different shades of gray. Okay. Anyone here worked on Mammo? They have a phantom that they put on there to show the different shades of gray. How is contrast used? What modalities use it? And how does it enter the body? Again, what is contrast? We've all heard it used in the hospitals, right? So contrast, also called a dye, which is not what it is. Does this look like a dye? It's clear, correct? So it's not a dye, but everyone refers to it as a dye. It's a material that is injected into the body to provide contrast to soft tissue. And how does it do that? In an X-ray or CT, how does it give you that contrast in the body? It attenuates the X-ray. Now, what does attenuate the X-ray mean? We've all seen an X-ray before, right? The X-ray hits the body, and what shows up on the back on the screen or on the film? The image. Okay. With the image, what shades is it? It's a different. They all have different shades of gray, right? Now, what does bone show up as? White. Why is that? No, it blocks the X-ray. So the film that you're seeing is a negative. Okay, so the dark is what's going to be soft tissue, and the white is going to be bone or hard tissue. Now, that's not very good to looking at muscles, veins, arteries, and such, is it? Because the X-ray blows right through the veins and arteries and soft tissue and only shows the hard tissue. So the contrast, the fluid that is put into the body, helps to distinguish soft tissue. And that is used for a lot interventional radiology for blood clots and blockages, or CT to find calcified objects or tumors. That's another one. And it's used tremendously in heart catheterizations. Tremendously. So contrast is not a dye. It's a clear liquid that blocks X-ray. So if it blocks X-ray, what's going to show up on the film? White. It's going to show up white. And that's how they can distinguish hard objects. Here's a contrast. This is a CT. That's non-contrast. And then with contrast, you can see it's highlighted certain areas. Because the contrast fluid, what does it do? Blocks X-ray, so it shows up white. These images aren't that exciting, are they? It really doesn't give you a, wow, this is really some neat stuff, right? Okay, here's another one, with and without. This enhances this area and shows up white because it blocks X-ray. Okay, this is a heart catheterization. Do we all know what a heart catheterization is? Anyone who doesn't, I'll be more than happy to explain it to you. I've had 5 in my lifetime. So we all understand what heart catheterization is, right? You see how before you don't see that, how it shades up in here and you can't see anything here? You can't see any blood vessels or anything, right? Now you do. That's what contrast does. But why is it dark here and not white? Why in CT is it white, but in a heart cath or interventional, it's dark? Why is that? No. Good guess. but it's still going to block X-ray. And if it blocks X-ray, it's going to show up white. So why does it show up dark here? Well, yes, it's inside the blood vessel, but on CT, since it blocks the X-ray, it's going to be white. No, it's a fluoro. It's still X-ray. The doctors use reverse imaging. So what white is dark and what dark is white. Why do they want to do that? Exactly, gives them a better contrast. It's just not a white blob up there. It gives them a better contrast. Exactly. They can see blockages. They can, so like in here, that's supposed to be open. It's not. And if you had a narrowing right down here, that would be calcification, cholesterol, whatever. And they go in with the roto-rooter and clean it all out and flush it out. That's how they know where to go. Right? I mean, it's great stuff. And I love the CAT stuff because it's so animated that you can actually see it working. So how does contrast enter the body? By an injector. There's an injector. We got the Stellan up here. We got the Mark 7 over here. We got the MR Experion. And then we have the old time syringe, right? Which would you prefer to be injected with contrast? Has anyone ever had contrast? Okay, how does it feel? Did you? Okay, I did. Okay. Oh yeah, get the blanket, man. Here it comes. It's terrible stuff. I had my first heart catheterization in 1966. I had my second one in 1975, and I had them throughout my life. But I remember having my in 1975. That was kind of the worst one. Is up at Cleveland Clinic, and they had the heart cath set up. It was in the middle, and they had two prep rooms, and they would wheel one in right after another, and it was just it was one of the worst experiences of my life that I can remember. It was, you know, it goes in you. It feel like it just was a weird feeling. It goes down through your hips and says, oh, here it comes. Yep. I'm sorry. Yes. Yes. And they have to, before they give you contrast, they have to check your kidney functions so your body is able to flush it out. That's how toxic this stuff is. Has anyone seen a contrast injector in the hospital? It's caked white, isn't it? A lot of white on it. Yeah, it's worse than super glue. It just gets on there and stuck, and you can't get it off. And the only thing that gets it off is what? Hot water. Okay. I had someone say, "Can I use a steamer on it?" Sure. It just rolls right down into the other stuff. You're not cleaning it off. So what is a contrast injector? And you can read it if you want to. It's mechanical, right? It's a mechanical device used to inject contrast into the body through an IV. What's the advantages of a mechanical device compared to the syringe? Specific dose. You got what's A for? That's for the contrast. The B is for saline. Okay. So precision. That's the advantages of a contrast injector. Ability to conduct accurate and precise injection. Triphase injections. Has anyone ever heard of that before? You have A side, which is straight contrast. You have B side, which is straight saline. Then you have AB. AB is a combination of contrast and saline. What is that going to do for us on the images? The doctor requests a 50 and a 50, so it's 50% contrast, 50% saline. What's that going to do to the image? It's going to be a different shade of gray, not like the movie, okay? But you can develop different shades of gray to give you better viewing, better imaging of what exactly you're looking for. You may not want that vein or artery completely darked out. And they do that a lot in CT studies for heart studies. They will do a contrast, then they'll follow with a contrast of saline, then they'll do a flush, which is straight saline. Why would they want to do a flush? It's like hitting the reset button. Get everything out of it, let's do it again. Let's go on a different side. Let's do something different. Let's get it out of that area. So its ability to reproduce protocols, dependability, okay? Dependability. These are very dependable units. What screws them up the most is, what do you think? Dry contrast. Contrast is conductive. Saline, salt water, is conductive. So what happens when it gets on the board? You get an error, you short something out. If you let it dry, you have a good chance of it working again. Okay? But that's the main culprit of injectors, is contrast. Getting in things, messing up with the sensors and such. Increased patient flow rate. How can an injector do that for us? It's efficient, especially in the CT area. The stellate, who's seen a stellate in action? Okay, the stellate is made, there's quite a few automatic things on there. Automatic extend, automatic retract, automatic fill, purge, you just push buttons. And the whole way, the way the stellate was set up, designed to, is you set the protocol on the display, you put your syringes in. When you put your syringes in, the rams go up to be filled. Meanwhile, you get the patient in, set them on the table for the CT. Now the injector is ready to be filled. You hook up your contrast, your saline, you hit autofill. The autofill fills it up to what your protocol says you need to. 100 milliliters of contrast, 50 milliliters of saline. You push that button, it automatically loads. You continue setting up the patient. You go start setting up the CT. You come back out. You disconnect the tubing, put your tubing on. Actually, you have to prime it first. Put your tubing on, connect it to the patient, and now you're ready to go. And that's how they work. Once the CT is done, you take off the 2 syringes, throw away the syringes, the rams retract, ready to go for the next time. You get rid of the patient. You send the patient out the door, and you do it all over again. When I was working at the Norfolk Hospital in Virginia, it was a 400-bed level 1 trauma, and they had 4 CTs going just for the ER all the time. And the patients were lined up down the hallway. They had 2 techs to position the patient, 1 tech to snap the syringes on, another tech to enter the protocols into the syringe, into the injector, and then another tech to enter the CT in. They were knocking them out in less than 10 minutes a patient, one right after another. It's built for speed. That is the only one, any injector for CT, those are the only ones built for speed with a lot of automatic stuff. Increased patient flow. Time saving and cost savings. How can a contrast injector do that for the hospital, for the patient flow? Our customer is actually the patient. So how can time saving and cost savings apply to our patient. I just explained it. Everything is automatic. And cost savings, it's only going to fill up what you're going to use. So you're saving money in contrast. I just heard Friday night that a typical case of contrast that normally ran for $350, $400, they have a shortage of it. It's up to $1,200 a case now in a week's time. So it's like liquid gold. Okay, let's talk about components of an injector. All injectors are going to have three major components. You can have display, user interface, injector head, and some type of control module. This is the stellant. Here's the Mark 7. Here's the injector head. Here's the user interface display. Where's the control module at? Where at? Right underneath it there. That's a real nice injector, I will say that much. The Mark 7 is a really nice injector. Here is a OptiStar. So you have the display, modules to control it, and the injector head. You have the assist CTA on the left, display, control module, power module, injector head. And now you have the Provis. Same thing, 1, 2, where's the control module? In here. Have fun with that one. Okay, that's probably one of the worst ones to work on. It's bulky, it's heavy, and in order to actually work on it, you have to have it connected, you have to pull it out, but the cables are only about this long. I suggest a milk crate. Milk crate works great. Right height, perfect. Again, the stellant, and here is an unusual injector. Has anyone seen this one before? How do you like them? Why do the doctors like them? Who controls the pressure? Who controls the flow rate? He does all of it, and doctors love control, right? So they have a hand switch about this size, and you have to calibrate it every time. You switch it out, and you have two buttons, air buttons, and you push it, and it'll inject, and the doctor can slow down the injection, speed up the injection, slow it down, and then when the syringe is empty, what happens? It auto fills. That's great, isn't it? You don't have to have the tech say, "Hang on, I gotta refill the injector." No, it auto fills. It hangs the bag right here. This is the syringe, the contrast sensor. It connects to the syringe in here, and it auto fills. Continuous. And how many patients can you do on one setup? You can run it. You can run up to 5 patients without replacing the syringe, the setup, the tubing, except the tubing going to the patient. And they can do that because the chain of contrast, the chain of saline, is never broken inside the machine. All they have to do is repurge it and then connect it to the patient. Speed, right? You never want to upset a doctor doing a hard cath. You never want to upset that doctor. He has his own routine. It's like a ballet that he does. And all those techs in there know exactly what they're supposed to do next, and they're ready for it. Basic operation of a contrast injector. What's a protocol? Just the word protocol. A set way of doing things. Okay? So now taking that off, I call the protocol your recipe for your soup. Okay? Your protocol, you're going to put the ingredients in the soup to make your final outcome. A syringe. What's a syringe? I forgot to bring one in. I'm terribly sorry. What's a syringe? A container for your contrast, exactly right. And then you have your arm. You have to go through a couple push buttons to arm the injector to make sure everything is safe. And then you go to the inject. You just can't push a button and let it go. You have your protocol. Is what's going to be included in the protocol? Flow rate. What's flow rate? Okay, you've been to class. Shut up. So yes, what is flow rate? Who works on infusion pumps? Okay, so you put in a flow rate when you check it, right? And your flow rate is milliliters per hour, right? Sometimes, yeah, or milliliters per minute. Okay, these suckers run at milliliters per second. Okay, we can inject 50 milliliters per second on some injectors. That's fast. So you have your flow rate, how fast you want the contrast to go into the body. Why is that going to be important? What does the contrast mix with when it goes into the body? Blood. And when it goes into the blood, what happens to the contrast? You can stand outside, okay? So it dilutes. So if the contrast dilutes with the blood, what happens to the pictures, to the image, to the contrast? Less contrast, which gives you a shade of gray besides dark. Now you notice that these injectors up here, they're kind of torn apart a little bit, but they have an A and B. The CVI, did you see an A and B that we talked about? There is no A and B. That's for cath lab only. Why is there no saline? There's no need for it. Okay? Doctors don't need it in their study. They want full-fledged contrast going into that patient for better imaging. Also, what you're going to have is when you have that flow rate, Stellant and MRI injectors only go up to 10 milliliters per second. But cath lab interventional injectors like the CVI, the Angiomat, Mark 5 Provis, Mark 7, they go up to 50 milliliters per second. Why is there a difference? Why is that? Right, they don't care about dilution rate. They want that contrast going in there. They want to see what's going on. So they don't need the saline. If they want to do a saline, they'll take a little syringe and flush it out. They don't need it. And they want that fast flow rate to get into the body as quickly as possible. Because they have a catheter either going through the arm or up the leg, sitting in that heart. And when they want to see the contrast, they want to see it. Flow rate, volume. What's volume? Go ahead. What's volume? How much you want to give. And I think the CVI only goes up to 20 milliliters per injection, doesn't it? But it'll go up to, I think, 20 milliliters per second too. It doesn't go up to 50. But so now what's max pressure? It's a new word, right? Max pressure. That is the pressure that you do not want to exceed while injecting. And I'm going to talk more about pressure coming up. But that's the max pressure. CT injectors will go up to 325. Cath labs will go up to 1200 PSI. It's a lot of pressure, right? So why do we set a max pressure? What don't we want to do? What don't we want to do? Actually, no. It has basically nothing to do with patient safety. I thought it was too for a long time, but it's not. Okay. Huh? No. pressure is needed for the flow rate. You set the max pressure so you don't blow up the disposables. Again, I'll get into that just a little bit further when we talk about pressure, of how that can happen and why you have to have a max pressure for the disposables. And there's the protocols, how it's set up. A side, 10, flow rate, volume is 70, 2.5, 29. A and B, what's B? Saline, or they also call it flush too. And then there's your pressure limit of 325. Basic functions of all injectors. You're going to have your flow rate. You're going to have your volume. You're going to have your max pressure set. Different protocols. These injectors will save repeatable protocols. Once they set up a CTA or whatever, or LCA or whatever, they want that protocol, it's set up, they can automatically recall it. Hold and pause. What's the difference between hold and pause? What does hold mean? No. No. Hold will stop the injection. It will not start again until you push a button. It requires a user intervention to push that button. It'll sit there basically all day long waiting to continue. What's a pause? Predetermined amount of stop. So it'll pause for a certain amount of time. I want, it's also called a delay. I want to have a 5-second injection delay, or I want a 5-second scan delay, because these systems will and can interface with your imaging modality. So you start the injection, and at 5 seconds, it will send a signal over to the CT or to the cath lab, or or the MR doesn't do it, and it'll start the scan. It'll start the CT up, or it'll start the imaging on the cath lab. So these will talk to the modalities. It's just a simple signal it sends over there, saying, except for Siemens, that sends over there saying, start the X-ray, and then the X-ray starts. And that's where the delay comes in. KVO, what's KVO? Come on. Keep the vein open. The only injectors that have keep the vein open is MRI. Why is that? Who's had an MRI done? Okay. How long does that exam take? I was in there for 3.5 hours. I had 4 injections during those 3.5 hours. So they stick the patient, they start the IV going, then they hit KVO. That is only do a small amount of saline. It's like milliliters per hour at that point. They don't want the vein to collapse. Then they do the first scan, which is 20 minutes. Then they're going to inject contrast. Then they're going to flush. Then they're going to do another scan. And the whole exam takes 45 minutes to an hour. MRIs are not fast, are they? CTs, 20 seconds, you're out, have a good day, pay me. Okay, MRI takes a long time. So they don't want to stick a patient. They don't want to have to keep going in and out of the room when they want to inject or stick the patient. They'll stick the patient right at the beginning. 20, 30 minutes later, they'll start the injection. They want to make sure that that vein is not clogged or collapsed. So it's keep vein open, a small drip. That's why it's on the MRIs and not necessarily on the CTs or cath labs. And test injection. They can do a test injection on some of these models, which is basically a simple injection of saline to make sure everything is working properly. And you'll see that. Some have it hidden in there on their protocols and such. I've seen that probably 30% of the time where they have a protocol with a test injection. Pressure. What's pressure? This is my favorite subject. What's pressure? Is this pressure? Me pushing on the wall? is this pressure pushing on the wall? If I bring a bulldozer in and push on the wall, is that pressure? Which has more pressure? Here, here, or the bulldozer? My finger has more pressure on it. It's the surface area. So the force applied perpendicular to the surface of an object per unit area over which that force is distributed. What does that mean? You're real close. The skinnier the tube, the more pressure is needed to maintain that flow rate that you want. The smaller the diameter, the more pressure is needed to maintain the flow rate of what you want. Okay? Let's take your garden hose. You turn on the spigot, water comes out. Is that pressure? No. Pressure is behind it. It's the release of pressure that you're seeing. Okay? It's the release of pressure. Pressure is in the pipes behind your open spigot. That's where the pressure's at. Now take that same spigot and you attach with a 1/4 inch, 3/4 inch or 3/8, whatever, 1/2 inch pipe. You put a 3-inch pipe on it. You run it 10 feet. Where's your pressure? At the end of that 10-foot hose. 0, right? There's no pressure there. Now you run that up a hill 100 feet. How much pressure is out there? 0, nothing, because it's a larger surface area. So you're taking a syringe that holds 200 milliliters of fluid, something just like this, and you're trying to push it through the small tubing, the IV tubing. Where's the pressure at? What is going to push that fluid through that tube? The plunger. What's pushing the plunger? Well, if you're dealing with a CVI, that's the motor. Okay? That's the motor. It weighs about what, 20 pounds? It's heavy. Why? Because it goes up to 1200 psi to push your fluid through that tiny little tube, what we were talking about, the diameter. And if you're working on a CT one, this is a CTA, there's the motor. Why? Because you're only going up to 10 milliliters per second. This goes up to 20, but even on larger ones, about the same size motor, it'll go up to 50 milliliters per second through a small tube, then into a 22 gauge catheter, then into a smaller catheter that's going into the heart. So where's the pressure on these injectors? It's all in the back. It's all where that motor starts to push everything out. That's where your pressure's at. So I love the fallacy that someone says, oh, I don't want to deal with injectors. They deal with so much pressure. Can you imagine putting 300 psi into somebody's arm? No, your tire only holds 45 psi, right? Now take it to 1200 psi. Why is there greater pressure? Why do I need greater pressure? Because of, well, you're getting there. What determines pressure? What determines how much pressure you need? Flow rate. Higher the flow rate equals higher pressure. Lower the flow rate, lower the pressure. Now, do you hit max pressure when you inject? No. Nowhere near it. Okay? The tubing can absorb up to 150 psi. The length of the tubing can absorb 150 psi. So with that being said, the pressure pushes, you need the flow rate to push the pressure. Pressure, what is pressure? We talked about that. Injector pressures, 300, 600, 680, 1000, 120. Those are test pressures that we use. We talked about what determines pressure, flow rate, viscosity, cement pump, right? Big old truck, right? The pump cement. Viscosity is thick. Concrete is thick, whereas water is thin, and contrast is thicker than water. So it all depends on what you're pumping, is how much pressure you need. Length of tubing and diameter of tubing. Max pressure. What is max pressure? We talked about that. It's to protect what? The consumables, disposables, right. Does it help protect the patient? Yeah, in a way. Things blow up, it doesn't always look nice, okay? Who determines it? No, well, in a way, yes. The package will have a flow rate specifications on there. I looked at one Friday night, it was 355 PSI for CT. So it was 25 PSI higher than what the machine would give out. And what's overpressure? Also occlusion. What happens? Infusion guys, girls? Injection stops. It stops. We have a problem. Stop. There's an occlusion. There's something wrong. Stop. What happens when max pressure is reached? Yes, it maintains. How does it maintain? Who said that? I can't see your mouth speaking. How does it maintain? What determines the motor speed? What determines motor speed, which determines pressure? Flow rate. So you get pressure limiting. What's pressure limiting? The reduction of flow rate to maintain a pressure below the set max pressure. See part of the graph over there. This is what will happen. It's a safety program in the software. You'll start off here, it'll go up, hit max pressure setting, do a little droop down, and then continue the injection at a lower flow rate. That's what happens. Very important in the injector world, right? And on the stellate, that's the graph you'll see. It's almost like an X-ray overshoot. Safety features. Single-use syringes. Stellate CTA have different systems in place to prevent you from reusing a syringe. Injector head sensors, syringe ID, correct placement, how much volume, head tilt sensor, air and line sensors. More automatic equals what? More sensors. Specific step sequence to arm. Some of these things are really, really specific. You have to do 1, 2, 3, 4, 5, 6, then shoot. If you don't, it don't let you shoot. Flow regulating and pressure regulating. How does it regulate flow and pressure? We talked about the motor, right? Almost all injectors out there have three things that must work together to regulate flow, pressure, and to monitor those also. The motor, which is right here. That's the motor. Encoder, which is right here. And the potentiometer, which is right in the middle. What's the difference between encoder and potentiometer? A little bit more. Encoder counts. It doesn't matter where it starts or stops. It just keeps spinning. When the motor spins, encoder spins. When the encoder spins, the potentiometer spins. And they all monitor through amperage regulating and also load cells on some of them. If they don't match, if they don't equal, it stops, gives you an error. They all must work together. One thing about the bare injectors, you can always find the blue pot. Motor, encoder. Motor, encoder, linear pot. Motor, encoder, motor, and the linear pot is right here. What is the difference between a linear pot and potentiometer pot? A potentiometer. Linear, and a potentiometer is spun around. So CTA uses a linear one, and Grebet uses a linear potentiometer also. So as the syringe goes up and down, it runs across that linear pot, tells the computer where you're at. Again, you see up here, potentiometer, encoder, motor. Push the right buttons here. Motor, encoder, and there's the potentiometer right there, linear. There. Solaris. Here's the potentiometer right back here. And here's the motor and the encoder down in the base. Completely separate on this one. Same thing, this is on the Mark 7, motor, encoder, and what do we got here? A blue pot. Very easy to find. And we just went over the CVI. And there's the, that's the CTA. There's the linear pot right there. It goes up and down. As the piston goes up and down, they have a wiper that goes up and down on that piston. Let's talk about basic troubleshooting. When you come across an injector that's having an error, always do an operations check, which is a basic no liquid injection. See where it starts and stops, where the error happens, what works, what doesn't work. That's the important thing. If you have A side and B side, does B side work and not A side, or they both don't work? Basic troubleshooting. What do I have? What don't I have? When did the error occur? On the Stellant, a lot of times an error occurs when you tilt it upside down or tilt it down to inject. Why is that? The technicians will use the head cable here to move the injector up and down. If the injector's pointed up, the head cable's good. When they tilt it down, it loses that, it breaks a wire, or the wire is broken, loses a connection, you get an error. Very common. A side or B side? Has anything changed recently? I had one site in Virginia, everything was working great. All of a sudden, they couldn't inject above 6.5 milliliters per second. Purchasing decided to go to a different size tubing, to go IV tubing, which was only rated at 6.5. So when they went above 6.5, they got an overpressure and it shut it down. Nothing like saving money that doesn't work, right? Use what's supposed to use. Yeah, they couldn't go over 6. It said right there, max flow rate, 6.5. They do a 7.5 injection, did not work. Basic PM procedures. Talk with the customer. The customer knows what's wrong with that machine. They use it day in, day out, right? They can, I'm having a little issue with this button here. Okay, great. Now you know what to look for. Record the protocol on the screen before you start. Why is that? Some of these techs only know what's on that screen. If you leave something different on that, they won't know what to do. Oh my God, it's broken. Really? I've seen that. Initial inspection. What's broken, what's not? Is it in good condition? How bad is the contrast on it? Mounting of injector. Yes, they have fallen from the ceiling. Operations check, perform test injection, verify functionality. Cleaning, this is going to take most of your time. Clean, 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 clean. Take the covers off and clean, 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 clean. A clean injector is a happy injector. Calibration verification injector is within specifications. They all have different specifications. If you're trained how to do it, it's not that difficult, is it? especially on a CVI. Come on now, okay? Final operations check. Whenever you leave there, make sure it's still running the way you left it, and enter original protocol. Don't confuse that morning tech when they come in. Review. Good, we're doing good on time. Contrast, what is contrast? Huh? Both are right. Here's the contrast, and then contrast is the difference. Shades of gray, shades of gray. What is a contrast injector? Mechanical device. Basic operations of an injector. Know how to push the buttons, right? Safety features. These things are filled with safety features. I have yet to see a patient harmed from an injector that it was not the technician's fault. These injectors have so many safety features built into them that 99% of the time, it's the technician's fault who did not set it up properly. Every one of them will say, did you check for air? You have to acknowledge that you check for air in the lines. That is the manufacturer's way of saying, hey, not our fault anymore. Every one of them, you have to say, check for air. How many times does the CVI have to be purged before it's happy? It's a minimum of 3 or 4 times. I mean, I think that screen asks you 4 times minimum, purge, purge, purge. And it knows if you purged or not. It does. There's a sensor in there that will see a little BB go up and down and a sensor to say, no more air. Yes. Pressure, we know what pressure is, right? Do a 1200 PSI go into the patient's arm? Why do we need 1200 PSI? Huh? To maintain the requested flow rate. So where is the pressure on these injectors? At the patient's arm or inside the injector? At the pump, well, motor. That's what we need. Will a technician ever see a pressure limiting happen? Very rarely, because I can tell you right now, 90% of the CTs injectors that I've seen are set at 300 PSI, and you ask them, can you change the PSI? Huh? What do you want me to do? Can you decrease your PSI to 200? How do I do that? You push that button and select 200 PSI. Hello. I had one cath lab tech, actually was in my training, and he said, yeah, we injected 495 PSI into that patient's arm. Yeah, no, you don't, okay? No, you don't, because no. Pressure limiting. What is pressure limiting? Reduction of the flow rate to maintain a pressure below max pressure. And troubleshooting. What works, what doesn't work. In-house injector program. Who has an in-house injector program at their hospital, clinic, or sites? You must, right? Okay. What's some of the advantages of it? Go back one more step. You said less downtime. Why? Why? Exactly. You're there. I have a problem in cath lab 4. I need you now. Those are the phone calls you get, right? Okay. You're there in 10 seconds. Okay. Are you from Arkansas Regional? Right outside Little Rock. I think we've done some repairs for you on the CVIs, on your older systems that you can't get parts for. Okay. I drove by it on the way here. So the advantages, a big advantage is the response time. And that's what the customer wants, the response time. Well, I'm waiting for them to call me back. No, they don't want to hear that. Response time. And how long do repairs normally take you? basic repairs. What's the percentage of your repairs? And how much, what, 90%? Why are you going to wait for an OEM to show up to clean up a sensor? Because that's all he did was take a warm washcloth and clean out that sensor to make sure it sees that contrast, right? Why wait for the OEM to show up? I'll be there tomorrow morning. I need the room for 3 hours. No, you run in there between cases, you have 15 minutes, you see the contrast bill, you clean it up and you're off and running. Most of the injector repairs, whatever you're on, take less than 90 minutes to fix. Even if you have to take the case apart, it's less than 90 minutes. Your hospital will love you. No scheduling rescheduling patients, no downtime, very little downtime. And if it is down, you can tell your director, I have to order a part. And then they can reschedule appropriately. And it comes into cost. Less downtime equals what? More productivity equals what? Less patient aggravation. Okay? The patient walks in, I'm here for my heart cath. He's here at 5 o'clock in the morning, and they come in at 6:30. We have to reschedule our injectors down. Or our injectors down, and we have to do everything in 2 rooms now instead of 3. So we'll get to you about 4 or 5 o'clock this afternoon. Who wants to hear that if you're the patient? You just traveled 2.5 hours to your hospital because your hospital was recommended, and now you have to tell the patient, see you tomorrow? Okay? So in-house injector programs. Injectors are nothing to be afraid of. They're a modified, they're a souped up pump. That's all it is. It's just a souped up pump, infusion pump. That's all it is. And believe it or not, even the pressures in the infusion pump get up there, but you don't really measure them. But it's all determined about the flow rate, not milliliters per second, or not milliliters per minute or milliliters per hour. It's milliliters per second. That's why you need the pressure. We did a sample on an MRI injector, injecting its typical flow rate into a patient. And at the end of the tubing with our pressure gauge, you know what we read? 2 PSI. That was it. And it was not the pressure, it was actually the release of the pressure. Well, we're just about out of time. I appreciate you showing up this morning and attending basic contrast injector theory. If you're interested in on your desk, you have tablets from Althea and my card, and you're more than welcome to give me a call with any questions that you have. Yes. We do, and we can discuss that afterwards. This is an educational seminar, and I will be available afterwards to answer any of your questions concerning our training program. Any questions so far today? Again, thank you very much, and enjoy the rest of the expo.